Welcome to the official podcast of the Ogden Surgical Medical Society. Since 1946, the Ogden Surgical Medical Society has been educating our medical community. In this podcast, we bring you the voices of medical experts in your community from around the world. Please note that the opinions and ideas shared on this podcast are those of the speakers and not the opinions of the Ogden Surgical Medical Society or its board. While medical topics will be discussed, it should not be taken as strict medical advice, and individual clinical judgment is warranted in a client's information to patient care. It is a responsibility to the listener to judge for themselves the applicability of the information discussed with regards to their medical practice.
The University of Utah's Midlife Women's Health and Menopausal Medicine program offers comprehensive care for midlife women, addressing perimenopause, menopause, and related syndromes. The program includes a collaborative network of medical providers and clinicians facilitating education and support for midlife women. We are excited today to interview Dr. Anna Nash, a provider from the University of Utah's Midlife Women's Health and Menopausal Medicine program, and one of our speakers at our upcoming Ogden Surgical Medical Society CME conference, Movement in Primary and Specialty Medicine 2026. Anna Nash is a women's health physician assistant who specializes in midlife and menopause care as well as women's sexual health. She is a certified menopause provider and has a PhD in clinical sexology. Her special focus emerged over the years of caring for women and recognizing gaps in the access to these areas. She is an advocate for women's education and autonomy around their health care. She believes in providing evidence-based care that is affordable and accessible to everyone. She advocates optimizing overall wellness, including physical, emotional, and sexual well-being throughout the lifespan. Anna is a Utah native, married with 4 children. She loves being outside in the sunshine, hiking, biking, and working in her garden. Welcome, Dr. Nash.
Thank you for having me.
Oh, we're excited to talk to you today. Thanks for coming. That was a great introduction, and it's very obvious where your focus and your interest is. And we think we're going to get a lot of great information from you now in this podcast, and also when you come up to Ogden for the meetings in May. So thank you. Maybe we could just lay a little bit of groundwork and have you help us understand what the terms menopause, perimenopause, menopause transition, all those terms that we hear and see in the literature, what do those mean?
Yeah. So perimenopause is essentially just the time leading up to menopause. It starts toward the end of the reproductive years and finishes on the day of our last menstrual period. Menopause is essentially a diagnosis of hindsight. It's defined by 12 months without a menstrual period. After that, you're considered to be postmenopausal, where you're no longer in that reproductive stage of life. Was there another term in there that you asked besides?
I see and hear the term menopause transition or
Yeah, the menopause transition is essentially broken up into 2 phases, early transition and late transition. The early transition is when there starts to be some changes in our menstrual cycles, maybe getting a little closer together, maybe spacing out just a little bit, maybe starting to have a few symptoms associated with fluctuations in hormones. And then the late transition is kind of the last 1 to 3 years where we'll start to see more than 60 days in between menstrual cycles and start having more symptoms of low estrogen levels, including hot flashes, night sweats, and vaginal dryness.
This will give you a broad opportunity to share, but what options do we have for treating menopausal symptoms?
Yeah, we have several hormonal and non-hormonal options for managing menopausal symptoms. In perimenopause, when women are still ovulating and have ovarian function, we oftentimes will recommend oral contraceptive pill to suppress the ovaries and manage their symptoms. Later toward the late transition, we may be adding some menopausal hormone therapy. We've kind of stopped using that term hormone replacement therapy and have substituted that with menopausal hormone therapy because we're not trying to substitute and replace what you had when you were in your reproductive years. We're just trying to give you enough hormones to manage symptoms as well as benefit our brain, our bones, and our cardiovascular health. Most women will opt for a menopausal hormone therapy unless they have some indication that makes them ineligible for hormone therapy. in which case we would go with a non-hormonal option. Our hormonal options for women who still have a uterus includes a combination of estrogen and progesterone. For women who've had a hysterectomy, it typically is estrogen by itself. Estrogen comes in oral forms, tablets that you take on a daily basis, as well as transdermal options, typically in the form of a patch, a gel, or a spray. And there is also an intravaginal ring, similar to the birth control ring that just delivers systemic estrogen. Progesterone can be given typically orally. We have yet to figure out how to get the micronized progesterone to absorb through the skin. So we typically are giving that to women to take in addition at nighttime, as it does help stimulate sleep.
That was a great summary. We could just shelf that topic for a little bit and see how time goes. But I'd love to come back and ask you a ton of questions about those treatment options and how to make those decisions. But the focus maybe that we could use your expertise on today is discussing sexual function and the menopause. Is there changes in sexual function, or does menopause cause changes in sexual function? And should we be aware of those as a clinician?
Yeah, absolutely. We see disruption, particularly to libido in the transition to menopause as the hormones are changing. A lot of women will experience a decline in their desire around sex. I tell people that our desire ebbs and flows over life. It certainly does take a hit during the menopausal transition, but oftentimes, if couples continue to work at it, that will return. But if it is distressing to them and they've been experiencing this for greater than 6 months, it's considered to be hypoactive sexual desire disorder, and we would then treat it separately. Oftentimes, though, we just start with regular menopausal hormone therapy, get them on some estrogen and progesterone if they have a uterus. And for a lot of women, their sexual function improves just on these hormones, but sometimes they need additional help, and we can talk specifically about those options in a minute. Also, in the menopausal transition, while we're having more time without as much estrogen as we're used to, we can start experiencing vaginal dryness, and that can cause discomfort and potentially even pain with intercourse. And I always tell my women that pain is the number one killer of libido. If you're having painful intercourse, you're not going to desire intercourse. So oftentimes we're looking at adding some, whether it's systemic hormones first, and then potentially some addition of a vaginal estrogen to help support them in terms of the dryness and discomfort. So that's kind of what's out there. I can talk specifically about treatment options, or we can do that later. Up to you.
Sure. You mentioned the dyspareunia or the vaginal dryness and pain. Is just me recommending vaginal lubricants, is that also an option? Or should I be thinking hormones immediately?
Yeah, oftentimes I tend to be a little more liberal probably with vaginal estrogen than other providers. You certainly could start with over-the-counter vaginal moisturizers such as Replens, and even women who are on a vaginal estrogen may benefit from using a vaginal moisturizer on occasion. Certainly, lubricants with intercourse can be a great addition. And when those are no longer enough, or they're not responding well enough to those, you could certainly look at adding a vaginal estrogen product.
So we have a variety of providers within our organization, with a great deal of those being primary care physicians and primary care providers, many of whom do take care of menopause. So why should we, in that setting, refer to a certified menopause provider? What's the advantage both to the patient and to the provider for that consultation?
Well, for many providers, especially if you were trained a long time ago like I was, we didn't learn a lot about menopause. And the Women's Health Initiative study came out and really made us question the decision about using menopausal hormones. So there can be some anxiety and discomfort around prescribing hormones for many in the community, which is understandable. A certified menopause provider has been through specialty training through the Menopause Society, specifically around indications and contraindications of menopausal hormone therapy, patient education, stuff like that. So oftentimes I tell people it's wonderful if your primary care physician feels comfortable starting some hormone therapy. And if they run into complications or concerns, certainly send those patients to us. or if the patient has a little bit more complex medical history that could concern a provider around their eligibility for hormone therapy. Those are also great patients to send to a menopause practitioner.
So I think that gives us a segue to ask a few questions about hormone replacement in the current environment. The Women's Health Initiative that you mentioned certainly caused great havoc, but I think in many ways we're recovering from that impact and providing hormones more readily. But what do you see as pretty solid contraindications these days to hormone therapy?
That's a great question. Honestly, with the use of transdermal hormones, there's very few black and white contraindications the way that there used to be. Oral estrogen does increase our risk for blood clots. So if you had a patient who had a history of DVT or PE or even TIA, those would be patients in which using an oral estrogen would not be advised. And also, I tend to steer away from oral estrogens if somebody has a history of liver or gallbladder disease, or if they have elevated triglyceride levels, as all of those things can be impacted with oral estrogen. With transdermal estrogens, because they bypass the liver, they're not metabolized the same way in the system. And therefore, there is minimal change to our clotting factors with the transdermal estrogens. I've bumped into cases where seizure disorders may change the way that we approach somebody's hormone therapy. Not an absolute contraindication, but a lot of neurologists prefer, even if they've had a hysterectomy, to use a combination of estrogen and progesterone. Obviously, breast cancer or a high risk, or if they have a BRCA gene positivity, may be situations where hormone therapy is contraindicated.
Would you throw cardiac disease into that list? A known cardiac disease or not?
Yeah, definitely for oral. And I'm always open to working with their provider, their cardiologist, neurologist, specialty providers in terms of deciding whether or not it's the right choice for them. Oftentimes, my ideal in the setting of cardiac disease would be to go with a non-hormonal option if possible. But if that's not an option for the patient, I would still potentially look at using a transdermal option at a very, very low dose.
Great. Back on the certification, menopause specialty certification, is that something, for example, that an internist or a family practice doc, is there a course or is there a pathway to get that certification?
Yes, anyone actually can certify. It's just through the Menopause Society. They offer a textbook for studying. Some limitations are that they only offer the exam twice per year, and you can only take it once in that setting. So if you don't pass the test, which is actually quite common, you may end up taking it a second time. But currently, that's the only pathway to actual certification.
How do we find someone that is so certified?
Through the Menopause Society, you can look up the practitioners that are menopause certified on their listserv. There are also I know a lot of people are using these private clinics such as MIDI Health, and they also have a list of menopause certified providers accessible.
Great. I don't know how your time is, but would you be willing to talk a little bit about sexual dysfunction and how the diagnosis is made, and maybe what are some of the categories of sexual dysfunction that we might run into?
Sure. Sexual dysfunction essentially entails one of four things. It could be arousal disorder, desire disorder, orgasm disorder, or pain disorder. In terms of the DSM-5, it has to be going on for more than 6 months, and it has to be distressing to the patient. Some people experience low desire, and in their relationship, it's not distressing, and that is not considered sexual dysfunction. It does have to be distressing to them. So, desire obviously being thoughts, fantasies around sexuality, difficulty kind of engaging and avoiding any type of sexual situation. A lot of women just say their brain just doesn't think about it. And arousal disorders tend to be around the physiology of preparing for intercourse. So that's genital sensation, lubrication, things like that. Orgasm disorders just being either difficulty achieving orgasm or achieving orgasm too quickly. There are also some conditions in which orgasm can be painful that also fit into that category. And then pain, which could be anything from dryness in the vagina, painful intercourse, to like a vulvodynia, which is kind of a hypersensitization of the nerves where there's kind of burning and irritation, as well as some chronic vulvar skin conditions that we see a lot of. So any of those things fit into the sexual dysfunction, and we certainly see a lot of them in the menopausal population.
How do I welcome this discussion with patients? As I see my patient population aging, and I'd like to have these discussions any way that I can open the door to be able to do that.
I think just asking is more than a lot of providers do. It can sometimes be something that's out of sight or out of mind, and we don't think to ask about it. I think it's great to ask about it in every age group, whether they're young and newly sexually active, if they're pregnant, postpartum, or in my case, mostly in this menopause population. Oftentimes, if they're given the opportunity, they are willing to open up about it, but they need to know that you're a safe person to open up to. And oftentimes, your willingness to just ask the question, do you have any concerns about your sexual wellness, can be enough for them to be willing to open up to that.
Sure. And I assume this is getting into the nitty-gritty, but there's probably a whole host of diagnostic codes that maybe I need to be aware of, or that we should be aware of if we're going to open that door.
There is a diagnosis code for low libido. I will use low libido in cases where it's not distressing, but if somebody really is stressed and wanting to address their sexual desire, I like to use hypoactive sexual desire disorder. It tends to have better coverage in terms of our medication options for treatment, and low libido tends to not have that accessibility. There is definitely a host of orgasm disorder diagnosis codes, as well as pain. Dyspareunia is kind of that umbrella code that you can use. Certainly, if you're finding that it is more pelvic floor related, you can use specific codes for pelvic floor dysfunction versus vulvodynia. So there's a whole host of different codes that can be used. But if you're not sure, there's certainly just very standard orgasm disorder, dyspareunia, and low libido that you can use, just less accessible to medication coverage, it seems like, with the low libido.
Sure. Thank you.
Well, I assume when we see such a patient and we've entered into a discussion that often our first line therapy is going to be hormone therapy. How often are you using antidepressants in that kind of setting as well?
Yeah, I certainly still feel like there is a place for other treatment modalities. Certainly in the cases where hormones, for whatever reason, are not the ideal option, particularly in perimenopause where they're still having ovarian function and menopausal hormones can kind of wreak havoc on their own cycle. Oftentimes I'm looking more toward an antidepressant in those types of cases. Certainly in sexual dysfunction, if you're picking up on an anxiety component or a depression component, anhedonia can certainly cross over into sexual function as well. Particularly if people have a long history of these types of symptoms, they may be exacerbated in the menopause transition, in which case they may respond quite well. I know from my experience, social media has really impacted the way that patients view their menopause transition. And oftentimes they're being told, if your practitioner just offers you an antidepressant, they clearly don't know anything about menopause. And these are all tools that we have, and they shouldn't be discounted as that. There are some people whose anxiety or depression, especially in that late transition, will be benefited by some hormone therapy. But if they don't improve with hormone therapy, or if they have a long-term history, an antidepressant is absolutely still a good first-line therapy.
I'm going to maybe ask for rapid fire here. You've segued into something that I hear fairly often from patients, and that's a request for testosterone from a female patient or a phosphodiesterase inhibitor any evidence, or should I be thinking about those? Or
Yeah, great question. So we have really good evidence around testosterone and libido, desire. Most of that data comes out of Australia. Susan Davis is the lead testosterone researcher. I tell people there is no direct correlation between testosterone level and your sexual function. That has been proven in these studies. And about 50 to 60% of women who choose testosterone as their treatment method will benefit in terms of libido. And I tell people oftentimes that's just the complexity of libido. It's biopsychosocial, and we can give you all the testosterone in the world. And if you're not in a healthy relationship, or, if you have severe anxiety, we might not be benefiting you with testosterone. I am currently hearing testosterone being used for us all sorts of other things that we actually really don't have data for, particularly fatigue, brain fog, things like that. We really don't have sufficient data right now on those particular issues. But for sexual function, it's a tool that we use if we've kind of addressed some of the other issues that may be lingering. Viagra, I have used off label. I use it more for orgasm disorders versus like a desire disorder. We do have 2 FDA approved medications for female libido, Addyi or flibanserin, and Vyleesi or bremelanotide. Both of those have FDA approval for female libido. And Addyi was recently approved in postmenopausal women, where it was initially only approved in premenopausal women. So we have access to both of those. They're both not generic, so they are expensive. A prescription for Viagra is very inexpensive. So sometimes it deters people. But again, using that hypoactive sexual desire disorder, if prescribing those medications, will definitely improve access and cost.
and you would take that episodically then?
Yes.
Okay.
Yep. It's a hot topic right now, and it's challenging because everybody wants it. And we don't have an FDA approved option. We can use male doses and divide them by 10, which is a little bit cumbersome if we're using like Testum or Androgel. Or the only other option we have is to compound them. And we really need to go through somebody who does enough of it that they feel really comfortable doing it. So I kind of have 2 or 3 main pharmacies that I will use for compounding testosterone if that's the direction that they want to go. And we're checking baseline testosterone levels, again, not because it's telling me anything about your libido. Our main goal is to keep you in female physiologic range to minimize potential side effects. We're repeating that level at 3 months into therapy, and again 6 months after that.
But there's still a possibility of virilization even at those low doses?
Yes, we all have different bodies and different sensitivities. So we use a typical 5 milligram dose of testosterone in women, and I've seen that push women past normal physiologic range, which is again why we check. So yes, I tell people the most common thing is voice changes. They may be subtle, but they can be there. And we do have to be careful because some of these virilization side effects can be permanent.
Well, I'm just fascinated having you here, and I love asking questions. So maybe you'll take one more from me at least. What about menopause and sleep, and how that all feeds? I mean, is there a sleep disorder that's associated with menopause, and does that feed into sexual dysfunction?
Sleep impacts pretty much every aspect of our lives. There's really good studies looking at how it impacts many different areas of our health. There certainly can always be an underlying sleep condition, so you never want to rule that out and assume that it's just menopause. Certainly they can still have sleep apnea or, other things, but we do see changes in sleep with menopause, and oftentimes it looks like waking in the early hours of the morning and not being able to go back to sleep. So people will complain of waking up at 3 or 4 a.m. and having a difficult time going back to sleep. Certainly hot flashes and night sweats can wake people up as well. So just, minimizing those through management, whether with non-hormonal or hormonal options, can help their sleep. The micronized progesterone that we use, Prometrium is the trade name, it actually impacts the GABA A receptors in our brain that help with sleep. Oftentimes we are using progesterone an hour before bedtime if they're having difficulty with sleep. Again, I'm always reassessing. If they're still not improving despite hormone therapy, you don't ever want to rule out that there could be some other underlying condition as well.
Well, as we close, I want to thank you for spending some time with us, and we are definitely looking forward to you joining us for our live conference this coming May. But as we do so, a final question for you to tackle as you bid us goodbye. What do you see as the cutting edge on the things that are coming that you are excited about?
Ooh, great question. I think the biggest need right now in terms of menopause management really is in our breast cancer survivors. We had a study come out this past fall called the PROMISE study, where they looked at an estradiol combined with a selective estrogen receptor modulator and its impact on some of these early breast abnormalities like DCIS and atypical ductal hyperplasia. That's going to be really fascinating to see how that looks once they start broadening that into other breast cancer potential management. We've also had a couple of non-hormonal options that have come out that affect the neuroreceptors in our brain that impact temperature control. So we have Veoza and Linquet that are both available on the market as non-hormonal options for vasomotor symptoms. And certainly I'm just looking forward to a lot more research as time goes on. That's definitely been a big gap. And we haven't had a lot of research since the big Women's Health Initiative study. So I look forward, obviously, to more data coming forward.
Well, thank you. Thank you for joining us today, and we look forward to seeing you in May.
Absolutely. Thanks for having me.
Really, we appreciate it. Thanks a lot.
Yeah, absolutely. Hopefully that's helpful and not too much.
More ahead.
More ahead, that's right. Please, I'm always happy to answer questions. We could use more and more of the primary care physicians being open to prescribing. And I can't remember if Camille Moreno is also speaking at the May conference.
Yeah.
Okay, so she's speaking on the menopause piece specifically, and I'm speaking on the sexual health piece. So hopefully, and we got a grant. We're doing 2 CME courses at the U this year in June and October for people who want to come and learn more about menopause management. I do have to say the menopause exam is kind of a beast, and the book that they use for their study guide is not super helpful. And so I know a lot of people have had to take it a couple of times, which can be frustrating and costly. This will kind of give people another opportunity to come and learn, just do a weekend CME to kind of buff up those skills a little bit.
Yeah, I wonder how does you publish those CMEs? I mean, I feel like I'm not in a loop with the use. I don't know how do we
Yeah, we're actually trying to, we have a flyer that we've developed. We're trying to get it out to all of the different associations like the Utah Family Practice Association. And so hopefully you'll be seeing it, but certainly as soon as we've got it, I'm happy to email it on to Teresa and she can forward that on.
That would be great. So is the CME through the U of U then?
Yes, it will be through the U. Mm-hmm.
Okay, that's great.
Thank
you so much.
The UMA is another great resource. They put all the CMEs that people sent them, in their magazine every month.
Exactly. Yeah. So we're trying to get, all that kind of all those different resources. So you should be seeing it. Fingers crossed.
Okay.
Thank you so much.
Have a great day.
All right. You're very welcome. Thank you so much.
Thank
Bye-bye.
you. Bye-bye.
Bye-bye.
Thank you for listening to our podcast. This episode was produced by Clark Madsen, Teresa Pasquedra, and the Board of Ogden Surgical Medical Society. Our executive director is Teresa Pasquedra, and editing and sound designs were provided by Zoe Mosher, with the support of the members of the Ogden Surgical Medical Society. Thanks again for joining us, and we'll see you in the next episode.